My name is Michelle Tregear, and I am the Chief Programs Officer for the National Breast Cancer Coalition. And I am also a 14-year breast cancer survivor, and I'd like to welcome you all to this year's National Breast Cancer Coalition's Project Lead Advanced Topic Session. We're really delighted that you could all be here, and hopefully more will join us from the Advocate Lounge. So, as I think many of you know, NBCC collaborates with the Alamo Breast Cancer Foundation to provide this advocate program at the start of the annual San Antonio Breast Cancer Symposium, and we've been doing that for a number of years. So I want to just say a big thank you to Alamo and its sponsors for helping to make this event possible. And then I'd also like to say a big thank you as well to NBCC's sponsors for helping us to make this program available to you all, and I've listed those here on the slide. So today, you guys are going to hear from an esteemed breast cancer researcher, Dr. Nicholas McAndrew, and you're going to hear about the current state of play of HER2-low breast cancer and what it might mean for the future treatment of breast cancer. Now, we've heard a lot about HER2 low and HER2, et cetera, this year. And it's also going to be a very big topic of discussion at this year's symposium. You're going to also hear from an advocate, Beth Emery, who's going to provide a advocate perspective on this topic. She's a longtime NBCC advocate and also an advocate for the Alamo Breast Cancer Foundation. And I'll introduce her here in just a moment. So one of the things I would like to we always start out our sessions, educational sessions, any session that we host, with a moment of silence to remember someone who has lost their lives to breast cancer. And so I'd like to invite Marilyn Miner of the Virginia Breast Cancer Foundation and the Vice President of the National Breast Cancer Coalition's Board of Directors to present that moment of silence.
Good morning. Katie Petridis was diagnosed with breast cancer in 2012 at the age of 25. After her diagnosis, she immediately became an advocate, first educating for herself and her treatment, and later using the education she gained to advocate on behalf of others. Bitten by the travel bug at an early age, Katie had a passion for travel and engaging with other cultures. She traveled to more than 20 countries in 31 states throughout her life. Kate was accepted into Young Survival Coalition's RISE program, and through this program took advantage of additional advocacy opportunities, including attending the San Antonio Breast Cancer Symposium and becoming involved with NBCC. Kate graduated from Project Lead in 2016 and attended NBCC's Advocate Leadership Summit. She participated in Lobby Day and continued to lobby every year for the DoD Breast Cancer Research Program. She used her voice to talk about being a breast cancer survivor, authoring a series of articles in the Washington Post, and later participating in an interview for our NBC Life podcast. In 2018, Kate was diagnosed with metastatic breast cancer shortly after marrying her longtime love, Brendan. After her metastatic diagnosis, Kate strengthened her advocacy and joined Mediviver. Kate passed away at the age of 35 on September 27, 2022. Please join me for a moment of silence to honor the life of Kate Petridis. Thank you.
So just a few things before we get started. I wanted to ask you all to hold your questions. Dr. McAndrew is going to come up and do a presentation. And what we'd like to have is, we're going to have, Beth will do her advocate perspective after that, and then we're going to do a moderated Q&A. And so we'd like to have you hold your questions until that time. I will be circulating with a mic. We have people who are watching this on live stream. Welcome, everyone. And so we want want to make sure they can hear any questions that are asked. So please hold those questions. If you have any, jot them down, and we will get to them. All right. Now, the other thing I wanted to do is just make you aware of a couple of upcoming events. We have the NBCC Advocate Leadership Summit, which is happening in May 2023, and it will culminate on May 9th with our annual lobby day, and we hope to see as many of you as possible there with us. And then we also are doing a 2023 Project Lead Institute in La Jolla. That is all scheduled, and it runs from July 30th through August 4th. So if you haven't been to Project Lead, though I think most of you have, we hope to see an application submitted. Our applications are open. But why I'm really telling you all about it, since most of you are Project Lead grads, is you are connected with the advocates who might benefit from this program. So if you know of any individuals that want to get involved, who are interested not just in the science, but also want to become advocates and work toward our mission of ending breast cancer, please, make them aware of this program. And you can go to our website, stopbreastcancer.org, under events, and you'll find information about both of these programs. All right, so at this time, I would like to introduce our moderator for the session, Beth Emery. As I say, she will also be giving the advocate perspective. So Beth Emery is an 11-year survivor of stage 3 HER2 breast cancer. She is the past president of the Alamo Breast Cancer Foundation and also their alternate on the National Breast Cancer Coalition's Board of Directors. She's also a member of the NBCC Board of Trustees. She's a graduate of Project Lead Institute and Public Policy Project Lead. And she uses that training as a consumer reviewer on Department of Defense breast cancer research program panels, and also in her policy advocacy for Alamo as well as NBCC, and also serves as a Texas team leader for NBCC since 2010. Beth has her bachelor's degree in journalism from the University of Oklahoma and her law degree from Harvard Law School. So welcome, Beth.
Thank you. I guess I could have done that from down there. It is my pleasure to introduce Dr. Nicholas McAndrew to you. And for those of you who were HER2 positive, he knows everything about it. It's really been terrific visiting with him. He worked with Dennis Slayman at UCLA. He's a professor at the David Geffen School of Medicine. He's a hematologist-oncologist practicing in Beverly Hills and Santa Monica, and he's a second-generation hematologist-oncologist. He did go back east for his medical training at the University of Pennsylvania, but as all people who were born in Texas come back to Texas, all people who were born in California go back to California. He is going to have a really interesting program. Hold your questions till the end, and then we're going to have some great questions and answers. We'll have plenty of time to cover everything. Thank you.
Thank you so much for that kind introduction. So I'm so excited to be here today. I really love Project Lead, and this is my second time speaking at a Project Lead event. Part of the reason I love it so much is, as Beth mentioned, I'm a second-generation oncologist. My mother is a breast cancer specialist as well, and I'd asked her why her patients love her so much, because anyone who knows my mom, and has had the opportunity to, be with her in the clinical setting knows that she's a lovely, warm person, and she's totally my inspiration for being an oncologist. And I asked her why her patients love her so much, and she said she just focuses so much on education, and she focuses so much on teaching. And so it's really a pleasure for me to be able to speak about the science of breast cancer and really get into the nitty-gritty with people who it matters most to patients and patient advocates. And so I really love doing this, and so thanks for affording me the opportunity to come here and speak today. So I'll be speaking today about HER2 low breast cancer, really a new emerging therapeutic category recently within the last several years. These are my disclosures. So here's a brief outline of what I'll be talking about. I'll be talking about first, I think just the general mechanism of action of HER2. What does the protein actually do, just as a reminder? And then what is HER2 low? What does that necessarily mean? And then also just differentiate how something like trastuzumab or Herceptin works as compared to these new antibody drug conjugates focusing on trastuzumab deruxtecan, as that's really the most relevant drug in this setting right now. And then also briefly talk about the bystander effect and how that sort of applies to HER2 low. We'll go through some of the clinical trial results with trastuzumab deruxtecan in the HER2 low setting, and then also go on to discuss some issues with diagnosis, issues of concordance and agreement of diagnosis, and then talk about some challenges moving forward, importantly focusing on interstitial lung disease and pneumonitis, which is probably the most important adverse event for this drug. Excuse my voice, I'm just getting over a bit of a cold. Today's actually the best it sounded in several days. So anyway, so in terms of the mechanism of action, I like to always differentiate because we talk about receptors a lot in breast cancer. And so the first receptor we really knew about in breast cancer is the estrogen receptor. So if you look at the cartoon here, this is to demonstrate what the classic ligand receptor binding sort of paradigm is, where you have some kind of ligand or some kind of molecule that's going to engage with the receptor. So in the case of estrogen, you have the estrogen molecule circulating throughout the bloodstream. It then will travel and bind to the estrogen receptor like a ball going into a socket. And then once that happens, that triggers a downstream cascade of events, which tells the breast cancer cell to grow. Now, in terms of something happening causing the cell to grow, it's the same with HER2. However, it's not the same ligand receptor binding paradigm we see with HER2. These are going to be the little blue receptors on the bottom there. With HER2, it's normally expressed in a small degree throughout a variety of tissues in the body, including breast tissue. So when we say someone's HER2 negative, it's probably more appropriate to say they're HER2 normal because it's normally expressed. It doesn't activate by receiving some kind of signal. It activates by dimerizing or pairing up with a neighboring HER-related protein. So when you have HER2 and HER2 binding together like this, where you have one HER2 protein sort of joining with the adjacent one, that will also tell the breast cancer cell to grow. And so HER2 amplified or HER2 positive breast cancer is where rather than just having a few of these around, you have way more of them around than you're supposed to. So you have an overexpression, and this is what Dr. Slayman described in his famous science paper from the 80s, that in about 20% of breast cancers, they're driven by this much more frequent dimerization. So when you have so many more of them around, as you can see, they're going to be much more likely to pair up with each other, and that's really going to cause the breast cancer cell to grow. This is characterized by more aggressive growth, more likely to metastasize, and there's a number of cellular events, including increased expression in VEGF, increased DNA synthesis. We see in the test tube in soft agar, we see it grow faster than other breast cancer cell lines, as decreased estrogen response and increased tamoxifen resistance. So when we look about how those tumors tend to behave, as we all know, this light blue line that the arrow is pointing to shows the probability of survival over time with, this is before Herceptin. So this is with how the natural history of HER2 breast cancer will perform. It has one of the worst prognoses went before the era of Herceptin. And so how something like trastuzumab or Herceptin works, it blocks that HER2 to HER2, what's called homodimerization. So heterodimerization would be between something like HER2 and HER3, but Herceptin blocks HER2 to HER2 homodimerization. So here in the upper corner, we have a cartoon of something like the Herceptin antibody here. And so what that would do is then it would travel over to a HER2 protein and it would block the attempt at homodimerization there. So you won't get that pairing and you won't get that downstream growth that the increased expression of HER2 wants to promote in the breast cancer cell. And of course, when we see that happen, we see a total change in the natural history of HER2 positive breast cancer. In the orange line on the top, that represents sort of the best of the survival curve seen here in this combined analysis from Dr. Daywood. And really, it took HER2 positive breast cancer from having one of the worst prognoses to having one of the best prognoses. So this is all just a little bit of background, because I think it's important to differentiate in our mind how we think about HER2 positive breast cancer, what those treatments do, how they work, and then how this is different. So antibody drug conjugates, rather than blocking how the proteins want to work, they use that protein as an entryway into the cell, as a vehicle to get into the cell, rather than manipulating how the entryway works as a part of the cell's life cycle. So an antibody drug conjugate will have an antibody that is targeted against some kind of target, in this case HER2, so it's actually the same trastuzumab monoclonal antibody, except it's conjoined to a chemotherapy payload of some kind. So the first one that came out was TDM1. The payload will be released once it's inside the cell. However, not all antibody drug conjugates are designed the same way. So trastuzumab emtansine, which is Kadcyla, has an antibody to drug to antibody ratio of about 3.5. There is the linker is quite different from the linker in trastuzumab deruxtecan. Thank you so much. And the payload, most importantly, is it's a highly potent tubulin destabilizer, so it's somewhat similar to taxanes. However, it doesn't seem to permeate throughout the membrane. Whereas trastuzumab deruxtecan, as a second-generation antibody-drug conjugate, has a much higher drug-to-antibody ratio. So per molecule of the antibody, you have about 8, on average, drug molecules. As a cleavable linker, so that it's released from the antibody once it's inside the cell by the lysosome. And then its payload is different. It's deruxtecan, which is a highly potent topoisomerase I inhibitor with a short systemic half-life, but it's also membrane permeable. So when we think about the bystander effect, really what it's saying is that there's some relevant portion of the tumor that can be targeted by the antibody, and that's what we want to see. We want to see that there's at least some of the target around in the tumor. We don't need to necessarily see all the tumor cells expressing the target. So once the ADC, so here's my cartoon of the antibody drug conjugate with a couple of the chemo payloads conjoined to it. It will enter the cell through HER2. It'll go there and get inside the cell. Then once it's inside, it will release the chemotherapy molecule, and then that will go to neighboring HER2 negative cells. So this is a way to affect kind of like the surrounding area. If you think about antibody drug conjugates as being a smart bomb, this is kind of like a dirty bomb. It sort of gets the neighboring surrounding area. And so this is what was seen in the laboratory. And just as a reminder about how well this drug works in HER2-positive breast cancer, so this is still in the HER2-positive space. Most recently, the DESTINY-Breast03 study was compared in the second-line setting in metastatic breast cancer patients for trastuzumab deruxtecan versus trastuzumab emtansine. And we saw a really remarkable improvement in progression-free survival, one of the best improvements we've ever seen. And then also in overall survival too. It's still early to tell, but we see this curve separating on with regards to overall survival. Then in terms of how much it shrinks the tumor cells, these are going to be important plots to get used to seeing, especially in this space. These are called waterfall plots, and the way these work is that at the 0 point, which if you look at the gray line, that's going to be where the bars deflect from the bottom to where they change to deflecting up towards the top. Everything that's pointing downwards shows shrinkage of the tumors on aggregate by some degree. And so the two lines up on either side of the 0 mark represent 20% growth or 20% shrinkage. And so clearly this is an effective drug with many patients seeing a complete response and the vast majority of patients seeing a confirmed objective response. So that's just some background about how well this drug works in HER2-positive breast cancer. The first proof of concept study in HER2-low or HER2-normal breast cancer was a phase 1 study in which they looked at a variety of different doses of trastuzumab deruxtecan. And they defined HER2-low as having some degree of expression by IHC, which is immunohistochemistry, deemed as 1+ or 2+, but it had to be FISH negative. So that's how we diagnose HER2-positive breast cancer, as having either 2+ and FISH positive or 3+. So 1+ or 2+ FISH negative would traditionally be considered HER2 negative. These are all patients who progressed on standard therapy, and they were dosed every 3 weeks. And here we see significant response rate in all patients, with the patients with asterisks having also hormone receptor negative breast cancer. So these are patients who would be considered triple negative and really have a limited number of therapeutic options, because all the hormone positive patients would ostensibly have been exposed to a variety of hormone blocking treatments. So this then led to a randomized phase 3 study, the DESTINY-Breast04 trial, in which patients with HER2-low breast cancer who had previously received at least 1 line of chemotherapy and all lines of hormone-directed therapy were randomized to receive either treatment of physician's choice or trastuzumab deruxtecan. Give me one more second. I really am feeling so much better today. I don't know why this tickle in my throat is really bringing me down, but thank you for sticking with me. Anyway, this basically was trying to figure out, does trastuzumab deruxtecan work in HER2-low breast cancer better than standard chemotherapy? So this is after progression on at least 1 line of chemotherapy for patients who are hormone receptor negative, or triple negative, or after estrogen-based therapy or estrogen blocking therapy and 1 line of chemotherapy in the hormone receptor positive setting. And we see here that in the primary cohort, which is the hormone receptor positive cohort, there was a significant improvement in progression-free survival and then also in overall survival, which is pretty remarkable in the late line setting for trastuzumab deruxtecan over standard chemotherapy. And if we look at the estrogen-negative cohort, we see very, very similar results, that there was a significant improvement in both progression-free survival and also in overall survival as well. And if we look at the waterfall plots here, on the left is trastuzumab deruxtecan, or Enhertu, and on the right is the treatment of physician's choice. So clearly, when it comes to getting a response, this drug is much more effective than standard chemotherapy, even in the resistant setting. And this is just a comparison waterfall plot. So if we look at how well this works in HER2-positive breast cancer patients versus on the left, not too dissimilar. Certainly a little bit better in the HER2-positive setting, but pretty darn good for what we would consider previously, not really an appropriate patient population for these classes of drugs. So clearly, we've identified a new cohort of patients who can respond well to this form of treatment. Briefly talk about other drugs entering the space. We have drugs like trastuzumab deocarmazine, which is even further is different from trastuzumab deruxtecan, has a different payload. It's not clearly diffusible, but there were some studies in the HER2-low cohort. And we do see here some objective responses with trastuzumab deocarmazine and HER2-low, looking at the green graphs on the bottom there for the estrogen receptor positive and negative cohorts, respectively. So let's talk a little bit about how likely we are to see someone being HER2-low just in general practice. So this study looked at how likely patients are to be HER2 low versus HER2 zero. So in the two graphs on the bottom left, we see on the bottom left there that it's much more likely that someone is either HER2 zero or HER2 1 plus or HER2 2 plus in FISH negative if you're estrogen receptor positive versus estrogen receptor negative or triple negative. So about 65% of hormone receptor positive breast cancers will be HER2 low, either 1 plus or 2 plus. Whereas in triple negative breast cancer, or as I like to call it, double and a half negative breast cancer, it is 36%. So certainly much more likely in the triple negative setting, much more likely in the hormone positive setting, but less likely in the triple negative setting. But it still occurs in about a third of patients who are triple negative. Now, I think one of the biggest challenges is what about, actually diagnosing this, and how good are we about having pathologists agree that people are HER2 low? And I think part of the reason why we're seeing some of this disagreement, I'll go through this data in a second, is that you have to remember that really the most crucial thing for them to be right about was whether or not someone was HER2 positive in the past. And so that's how pathologists have really trained. They've trained themselves to really recognize when patients are clearly HER2 positive, because that's going to be the decision that makes or breaks the bank. If they're 1 plus versus 2 plus or 0 versus 1, it may not have made quite as much of a difference. However, so I wonder if we're going to see this data change over time. But this study looked at about 100 cases that were revisited by 5 different breast-specific pathologists at different institutions. And out of the 100, 35 of them had discordance by at least 1 out of the 5 pathologists. So about 15% of the 100 disagreed about whether it was 0 versus 1. 12 disagreed whether or not it was 1 versus 2. 6% disagreed whether it was 2 versus 3. Now, 1% disagreed whether it was 2 versus 0, so that must have been a strange case. And then also 1% disagreed 3 versus 1. So we're seeing the majority of them disagree about 0 versus 1, which can make a big difference in being able to, give somebody this drug. Because if they're 0 plus, you wouldn't be able to really get it covered for them. Now, in 25 out of 35 of these cases, only 1 pathologist disagreed. So the other 4 sort of agreed, but 1 did not. So it's important to keep in mind that maybe while we can see at least 1 disagree, what about how concordant are the pathologists as a whole? So if we look about the overall rate of agreement, so this kappa concordance score, it's a statistical test that tells us how well people agree between different raters of some kind of a test. For 0, the score was 0.82, which is also almost perfect agreement, actually. So most pathologists agreed when it was HER2 0. For 1 and 2 plus, there was substantial agreement, 0.67 and 0.74. And then for 3 plus, there was almost perfect agreement at a score of 0.95. So pretty darn concordant with 3 plus and 0 plus versus the 1 and the 2 maybe a little less so. Again, because in the past, trying to figure out 1 versus 2 may not have really made all that much of a difference when it came to assigning someone a treatment category, because with 2 plus, you're always going to reflex to FISH. And so maybe that wasn't really something that would have changed a treatment decision in the past. So maybe there wasn't as much investment by the pathologist to really make sure that they are strict about those scores. So let's briefly talk about some challenges in moving forward and focusing on pneumonitis and interstitial lung disease, and then also talking about looking at using trastuzumab deruxtecan in the early stage setting. So it's certainly the most important adverse event, and in Destiny Breast 04, which is the HER2 low study, the overall rate of ILD and pneumonitis in HER2 group was 12.1%. So 45 out of 371 patients experienced some degree of ILD and pneumonitis. Most were grade 1, so 13 patients or 3.5%, or grade 2, which is 6.5% of patients. Now, what does that mean? So grade 1 means you have no symptoms. You are feeling totally fine. You have no shortness of breath, and so you feel basically as many of you do now if you don't have shortness of breath right now. But what you see on CAT scan is you see ground glass opacities or areas of inflammation, so some haziness, so something that you could never tell unless you had a CT scan of the chest. Grade 2 is mild symptoms. So very, very mild symptoms. I have a little bit of shortness of breath, but I'm still okay. And then you also see those CT-related changes. Now, grade 3 was more rare. Only 1.3% of patients had grade 3, and there were no grade 4 events. And then there were some grade 5 events, which means that the patients died from it. And there were 2 patients who had experienced fatal ILD and pneumonitis on this study. Now, in DESTINY-Breast03, which was the other large randomized phase 3 study, there were fortunately no grade 5 events. But we know from the phase 1 data when this was an emerging side effect that we were starting to learn more about and didn't really have a healthy understanding of what this pneumonitis was like for this drug. There were more deaths from ILD from this drug, and so it really, in these studies, there were these groups that would convene whenever there was a suspected case of pneumonitis and adjudicate whether or not that was the case, and there were more strict guidelines for monitoring and stopping the drug if permanently discontinuing the drug if someone had a grade 2 event even. So really aggressive holding parameters for even mild ILD and pneumonitis, which for other adverse events and other drugs, if a patient experiences a grade 2 event from that drug, there's no other drug that you would permanently discontinue the drug for just a, or quote unquote, just a grade 2 event. But we know that you have to catch it early because the fact that we don't see many grade 3 and grade 4 cases means that if it gets really bad, it's potentially going to lead to a fatal event, which obviously is very, very important to recognize as early as possible. And I really think that it's important to recognize that while we see ILD and pneumonitis with other drugs, the CDK4/6 inhibitors can cause it to a rare degree. Immune blocking therapy or immune checkpoint inhibitors can cause it at a rate of 3 to 19%. This is different than the pneumonitis we generally see with trastuzumab deruxtecan. With ILD and pneumonitis related to Keytruda or pembrolizumab, for instance, which is a PD-1 inhibitor and an immune checkpoint inhibitor, it's typically steroid responsive. It tends to creep in. It's usually not fatal. And you can potentially try and re-challenge later. But the pneumonitis we see with trastuzumab deruxtecan is much more fulminant. It really comes on aggressively. And I think this is, as I mentioned earlier, really highlighted by the paucity of grade 3 and 4 events in clinical trials. It seems to be related to the expression of HER2 in the lungs when they looked at monkeys who were given deruxtecan monohydrate, so just the payload without the target on it. They didn't develop lung injury, although the monkeys that received trastuzumab deruxtecan did develop lung injury. So it does seem to be targeting HER2 in the lungs that leads to this event. But the exact mechanism's unknown. It's likely a combination of direct pulmonary cytotoxicity, meaning the drug itself is causing injury to the lung, as well as some degree of immune-mediated lung injury, so the inflammatory response afterwards that comes about after that injury has taken place, hence why we give steroids to these patients. In terms of monitoring for ILD and pneumonitis, in the stage 4 setting, which is where this drug is approved, patients receive CT imaging of the chest every 3 months. And so you're going to see grade 1 pneumonitis. However, in the early stage, there's no protocol that is associated with a CT scan of the chest every 3 months. And so how we practice medicine right now, how we practice oncology, isn't really set up to monitor for the earliest grade of ILD and pneumonitis that we see with this drug. And that's And what we know is that you have to catch this adverse event early. And so I really think that either we're going to have to figure out a different way of recognizing these patients earlier, or really strongly consider, while patients are getting this drug in the curative setting, so these are patients who may be cured with surgery alone in some cases, really thinking about whether or not we should start doing CT scans if we don't have a better option. Obviously, we don't want to expose patients to more radiation than we need to, but it's important to keep patients safe, especially when you're treating with curative intent and thinking that maybe they're going to be cured with surgery alone, because it's so much. It's just so important to keep patient safety in mind at the forefront. In terms of when this happens, the median time to ILD and pneumonitis is about 5 months, and so that means that many patients beforehand, but many patients later than that too. So it's not like if you make it past the first couple cycles, you're in the clear. And as I said earlier, we should really be thinking about whether or not we need to do CT scans every 3 months or so in these patients, and whether or not we have better biomarkers to try and recognize who these patients are likely to be. I'll briefly highlight my colleague, Dr. Sarah Hurwitz's investigator-initiated trial that we started at UCLA and was rolled out in the TRIO network. This was a neoadjuvant or preoperative study of trastuzumab deruxtecan in patients who were HER2 low in the stage 2 and 3 setting. She'll be presenting the data from this at San Antonio, so this is a bit of a teaser. So you'll have to, this data's embargoed. I'm not allowed to say anything, but it's quite interesting. We did put on a number of men and women on this study, and the study was actually amended later in the course of the study to increase the number of regimens to 8 cycles, given that we're trying to really see whether or not we see patients with a pathologic complete response. And so there was both a poster and a presentation at this year's San Antonio, so stay tuned for that. And with that, I thank you. I'll pass along the mic and be happy to take questions afterwards. This is our new bulldog, George, that we just got 3 weeks ago. He's extremely funny and loves to bite my ears, so thank you very much.
Thank you. I'm just going to say a few brief things, and I'm sorry some of you are like over there and I can't see you. If you want to move over, you may. First of all, most of you probably know, but one of the most distinguishing features of National Breast Cancer Coalition, and one of the things I'm most proud about, is that we focus on evidence-based medicine. And so these trials and understanding when a treatment is correct based on the evidence is very important to NBCC. And it is thus very important for advocates to understand the science and be able to communicate back home to patients in particular the importance of understanding exactly what the pros and cons of various treatments are. And this is because of a really important topic. There's the toxicity of the chemo bomb going off in your lungs, but there's also the financial toxicity, and it's one of the things that we're getting more attention on now. But it's for people who are fortunate to have insurance, there's still a financial impact because you have out-of-pocket costs and you probably have a copay of a certain amount. For example, let me get this right. So, for a patient with Herceptin, which is not as expensive as the new drugs, your insurance pays an additional $80,000. You have an additional $700 in out-of-pocket costs. That's assuming that you're treated locally and not going to MD Anderson like I did and flew there. And you have probably $2,000 or more in copayments. So these new and very expensive drugs have a financial impact. I will tell you from personal experience and from the experience of a very close family member, when you're faced with a breast cancer diagnosis, it's like, I want the most aggressive treatment possible because I don't want to die. I want to give myself the greatest opportunity to survive. And so you're not necessarily making rational choices. So it's really important that as advocates, we also work with the medical community to make sure that there's a good communication back and forth between patients and doctors. And I don't want to cast aspersions on doctors. I really think in most circumstances, they're trying to make the right decision for the patient. But I did not fully understand until the NBCC summit last year that doctors basically buy the chemo in bulk and then resell it in delivering it to the patients. And so they get a profit on that. So the more expensive the drug is, the potentially greater profit the oncologist has from that. So there are a lot of things swirling around. It's very important to keep that all in mind. I think as advocates in particular, we need to keep financial toxicity at the top of the list. And what I see here is, wow, metastatic, this is a no-brainer. Absolutely a no-brainer. But what do we do about early stage HER2-low breast cancer? And does this make sense in that circumstance? And do we know enough for this to make sense, particularly given the risks with respect to impact on the lungs? And I have a good friend who's here who had serious lung damage done because at the time she had breast cancer, people thought that stem cell transplants were a great idea. And, you know, so there are impacts to things. One of the things we do as advocates is continue to remind the scientists not to get excited about the next new shiny toy and to really understand that there are people who are impacted by what they're doing. So really important to understand this. I encourage you, there's a whole section on HER2 low, I think tomorrow. So that would be a really good one, I think, to go to understand this. The other thing that you mentioned briefly, and there's some great articles on it, if you look at the stains, it's absolutely clear who's got HER2 positive breast cancer. I mean, because those are like, you know, it just jumps out at you. But trying to distinguish HER2 low, I mean, that's an issue. There's an interesting article about using machine learning to analyze the slides, and you look at that may be an answer, but of course that's going to be another expensive test. CT scans are expensive. They're also, you know, there is some risk to regular CT scans. So there's a lot going on. What I think we have to do is understand this and say to ourselves, is this the right first-line treatment for women who have a good prognosis with typical treatment for hormone receptor positive HER2 low breast cancer? Let me look here. I also want to I want you to refocus a question I had on, you know, why is it that this in HER2 works when others don't, or works as well? What is going on in the mechanism, do we know, that seems to make it more effective?
So it's a good question, and you know, I think that part of it is that deruxtecan is a really potent chemotherapy. I mean, we know that this is a chemotherapy that when you give it without any kind of, you know, target shielding it from getting around the rest of the body, people can't tolerate it. And so when you are delivering it in these kind of more smaller doses and it's being kind of locally distributed, it's just destroying everything that's there, which is probably why we see the lung injury being so severe with it when it happens. Fortunately, it's less common, and the minority of patients overall will not receive any lung toxicity, fortunately. But that's probably why it's such a impressive degree of pneumonitis that we see, because it's such a potent drug. So I think the reason why we're seeing it working so much better than standard chemotherapy does in HER2 low is because it's just it's a stronger chemotherapeutic agent that is being delivered in a more kind of in a more targeted way rather than relying the way standard cytotoxic chemotherapy without any kind of target works, is that you're relying on the uptake of this on the cell to draw in the chemotherapy through its basically by absorbing it. The faster it grows, the faster it absorbs the chemotherapy, and so especially in hormone receptor positive breast cancer, which doesn't grow all that fast, doesn't likely have a growth rate that's going to allow it to really absorb the chemotherapy well, you're not going to see a tremendous amount of shrinkage. Whereas when you're sort of delivering it straight to the cell, you're going to be able to get it in there.
Although it's also it's membrane permeable, which
Exactly.
means it's also seeping out and attacking other cells in the lungs or someplace else, right?
Exactly.
Right.
Are we going to questions?
let's go.
Okay.
Great presentation. Thank you very much. So my question is, the patients that are very low incidence for the ILD, are there any trends in their overall health that would indicate, if I'm making sense what I'm asking here, it'd be kind of a watchdog type situation when they come into the treatment? Do they have like kind of a consistent health characteristic that would say, okay, I think they're going to stay on this pathway here? In other words, coming in a little bit healthier versus at a stage 4?
I wish there was.
Does that make sense?
Yeah, it does make sense, and I wish that there was. You have to be very vigilant, precisely because that's not the case. It can be anybody. I think this is a really sorely needed area of research and study, trying to figure out who are the patients who are likely to get this lung injury, who aren't, and how can we predict that? Is there a period at which point we can sort of say, okay, I think we're in the clear? And I think your question's a great one. Like the patients who don't, is there something that they're doing that causes that? Probably not. It's probably something about the biology of their lungs. But it's possible that there is something that they're doing. If that's the case, it's not something we've discovered yet, but I always think that that's important to keep in mind.
So, Dr. McAndrew, during your presentation, when you were talking about, the immunohistochemistry examination and the inner observer variability, you said, well, if it's 2+, it just goes straight to FISH. Can you talk just briefly about the real distinction between HER2 positive and what we see on FISH versus HER2, 2+?
Yeah, so because there is some normal degree of HER2 expression, and when we look at it on immunohistochemistry, if you read what the 2+ category is, it's really quite broad. And so there are several situations in which someone could qualify as HER2 2+. Either they could have a little bit of staining in a lot of the tissue, or a strong amount of staining but not in that much of the tissue. And so there are different circumstances that could lead someone to being 2+. And so the FISH really just gives a much more precise ratio of how many copies of HER2 are we actually seeing, and HER2 is produced on chromosome 17, as compared to the centromere for chromosome 17, so that sort of center point of the chromosome that serves as a reference point for something normal to some degree, that we should only expect to see one copy of that on that chromosome. So if we see that ratio go up, then we know that there's more copies of HER2 around than we should see. Now the problem is that there are also situations in which you can see people have an overexpression of that centromere. And so you can see falsely negative results, you can see falsely positive results. And I think that's one of the biggest challenges are these nuances in the FISH testing. It's not an easy test to do. And even at UCLA, we will send our borderline cases to Dr. Mike Press at USC's, the reference lab that we really tend to refer to when we have a challenging borderline situation.
And so is HER2 gene amplification really the sort of definer of who's HER2 positive versus potentially HER2 low?
Yeah, so if someone is HER2 positive by FISH, that's a better predictor than immunohistochemistry at response to trastuzumab.
Mm-hmm. Yeah.
So when they say that you're FISH negative, is that similar to when they said when you're HER2 negative, but now we're saying low?
Yes, and so if someone is FISH negative at diagnosis, then there are situations in which I've seen it be 3+ by immunohistochemistry, but then the FISH was done and that was negative, and then it's like, those are challenging situations, right? That's where no one knows what to do, basically, because that happens so rarely. But typically, FISH is used as the adjudicator when it's a borderline situation. Now, at UCLA, we run FISH on everything. At many other institutions,
MD Anderson does too.
Yeah, and MD Anderson does as well. At many other institutions, if it's 0 or 1+, FISH is not run. It's only in the 2+ setting.
I have one follow-up question that came when you were talking about. So who's going to fund the studies to do more understanding of who's at risk and who isn't? I mean, where are those studies going to come from?
I mean, I think to some degree, investigator-initiated studies, and they come from a variety of sources. There can be internal funding from universities if it's an easier study to do. Like, there's an available database that has that answer. You can apply through various grants to do that. You can apply for grants from pharma. I mean, AstraZeneca and Daiichi Sankyo have a huge, I think, responsibility to fund this kind of research.
Well, I agree.
And even perform it in the first place. But yeah.
Go ahead.
Hi, thank you so much for a great talk and a great explanation. As a patient, I have a question for you, doctor. With this FISH stuff, as patients, we go running around getting second opinions, sometimes third opinions about how to get treated. Should we be getting second opinions from the pathology?
I think that's a really good question. And I think that there are some situations in which it would make sense to get a second opinion through a pathologist. Now, as a patient, that's something that's pretty hard to do because you can't just make an appointment with the pathologist and say, hey, take a look at my my biopsy here. That's usually something that another oncologist does. And I've had situations in which patients were labeled as HER2 positive, come over, we reran the path. It was clearly HER2 negative, and it actually had a low oncotype score, so that patient didn't even need chemo. And so that was a huge difference in that patient's treatment experience, and what was the best thing to do. Now, do I think that do we rerun all pathology? Not necessarily. There are when everything is screaming that this is a certain type of breast cancer, the likelihood that reviewing the pathology is going to change things in many cases, I don't feel strongly to do it. But I think it's an important question to ask, and I think that if an oncologist is very thoughtful and is really taking the time to think, is this a situation in which I think there's a high likelihood that that doing a second opinion with pathology would yield a different result. It's very reasonable.
I think when you're showing the 1 out of 5 of breast pathology specialists are disagreeing, then that's of great concern to me, sure. Both at the negative level and at the high level. But thank you. Beth, I have to make a comment as a doctor. I find Dr. Lola yesterday in the seminar that we had also talked about the issues that doctors are facing now in the healthcare system. that after COVID, there's a tremendous amount of stress and burnout. When you talk about that doctors make a profit from giving the chemotherapy, remember that it costs us money to give the chemo also. You have to have an office, you have to have a nurse, you have to have the tubing, et cetera, et cetera. And right now, we're facing an 8.6% cut in Medicare reimbursements. So finances are going down, the income is going down, and it's a great concern. So I don't think people make a lot of money and make a lot of profit on the oncology. Some may, but most don't.
And I'm not speaking of any individual. The problem I have is that we've created a healthcare system in the United States that doesn't, in my mind, send the right signals. But of course, thanks to the United States, that's another great article that was in the New York Times yesterday. Thanks to the Washington Post, thanks to the United States, everyone else has low-cost drugs because we pay for it, and then they all get the benefit. So.
Right. I'm gonna take questions, so please raise your hand. I did want to ask one thing to Dr. McAndrew, and you're next, I think. Oh, okay. The HER2 positive, where we have gene amplification, we know that is probably locally driving the cancer, with the mutation in the breast tissue. Now, if somebody just has low HER2 kind of normal expression, is that potentially, I'm wondering if the ILD in a HER2 low population might be a little bit higher. And you can tell us from the results that have been presented so far, because perhaps these are patients who also express a little bit more normal HER2 in their lungs. We don't have any biomarkers yet, but hopefully they're going to find them.
Yeah, it's a good question, and so far as I know, that data has not been shown. The degree of HER2 expression is really, just a sample of something that you have when you're looking at the cancerous tissue also. So you're not necessarily doing that stain in normal tissue. You're doing that stain still in cancer tissue. So just by someone having a 1+ or a 2+ or even potentially 0 in the tumor doesn't necessarily tell us what their healthy tissue is doing. It doesn't tell us what the healthy tissue is doing in the breast, but it also doesn't tell us what it's doing in the lung. But these are exactly the kinds of biomarkers that we look at when we're trying to figure out whenever someone is likely to have either a treatment response or a side effect that we're trying to avoid. However, I think that's also important to consider. Like if someone says, "Oh, I'm 1+ or I'm 2+," that isn't necessarily a global trait for that person, nor is it a global trait within the tumor. You could biopsy one part of the tumor and it's 2+, and the other, the north side of it will be 0. That happens all the time because we know that cancer growth is not well regulated. That's a hallmark of cancer, is that it has unregulated growth, and so we see these what are called heterogeneous or different, types of tumors even within the same tumor cells within the same actual cancer.
Let me then follow up with one question. So for early stage breast cancer, HER2 low, ER positive, what is the guideline on when in HER2 would be a good choice? Do we know enough to know yet?
No, we don't. We don't know that we should really ever use it in HER2 low. Right now, it's still within the context of a clinical trial.
Yeah.
So the talent trial that Dr. Hurvitz designed is trying to even establish what, basically how often are these patients responding. And in all of my patients who I've put on that study, if it seems like they need chemotherapy otherwise, like if they had a high oncotype score, if they were premenopausal and had positive lymph nodes, then I'm giving them chemotherapy even after they receive HER2, because I don't want to rob them of what I know is the standard of care. Even if they had a great response to the HER2, I'm still saying, listen, I don't know whether or not that how much benefit that provides. So, those patients get a lot of treatment, and And I think that it's going to be very difficult to really know, especially because the outcomes in estrogen-positive breast cancer take so long to measure. It's going to be, I think, hard to know in which patients are we really giving a lot of benefit to with that drug, and in which situation should we say we don't need to use this shiny new toy, which I think is a great, analogy for how many of us will feel with this kind of thing. But at the same time, we need to have a healthy respect for the financial toxicity, which I would just like to briefly comment on. I think that's one of the biggest challenges I have as a doctor, is because it is such I say it's a challenge because if a patient asks me, it's not a discussion I shy away from, but if a patient asks me, hey, how much is this going to cost me? Well, I mean, I am at a large academic center, so there are several challenges that make it impossible for me to know what that is. One, the people who authorize our insurance, I've never met them. They live in some castle somewhere, as far as I'm concerned. And I, send a message to the pool saying, oh my God, please authorize this treatment regimen. And then, Alba, who's covering for Natalia, will say, okay, yes, they're covered, they're approved. I'm like, okay, great. And so, it's not only is it a giant bureaucracy even to get that then approved, but if back when I first started, I called up the insurance company. I said, how much is this going to cost for my patient? And they're like, we can't tell you. You have to put in the order first, and then we'll have to run it and see what their plan says. And then they can call and we'll tell them how much they're going to be responsible for. And that's different for every single patient. And so I would love to be able to counsel patients on how much it's going to cost, but I have no idea. And it depends from patient to patient. The main thing that I'm very happy about is that at, it being a large academic center where it's not a small private practice where I'm buying the chemotherapy and then reselling it. The thing I love, one of the things that I really love about my job is that no matter what I give to patients that month, my paycheck is the same. I have no sort of incentive that's driving me on a monthly basis to make different decisions, and it's such a relief to be able to practice that way.
Yes.
Hi, I had a quick question. Thank you for being here. I come from the same part of the country that you do, and fortunately, I think we have the UCLAs and the USCs and the MD Andersons and all those types of institutions across the country who have the breast-dedicated pathologists. What stuck out to me in the slide where you were showing, the agreement among breast pathologists, what happens when you move across the country and you have pathologists who are looking at slides from all over the body? How accurate are those? That really stuck out to me. Do we even know that? So because I live in Southern California and I have the ability to have breast pathologists looking at my slides versus somebody who lives in an area who doesn't have that. What are the differences? Do we even know that?
Yeah, I mean, I think it's a great question, and it's an important thing to keep in mind in general when we're looking at this data. How well does it apply to the entirety of the country and even the world? We know less about that particular data, partially because it'll be breast-specific pathologists who will tend to participate more in research, and so you already have a selection bias there when you're even selecting people who are going to participate in a study like that. But in general, I think that the concept of high agreement among 3+ and 0 remains true for pathologists in general. It's that middle category that tends to give us the biggest trouble.
But do we have enough information to know, at least in the metastatic setting, whether there's enough to be worried about on really wanting to know whether it's 1, 2, or 0? I mean, would you use HER2 in a metastatic setting for any of those, or?
If a patient has consistently been 0, then I would not.
Okay.
If they've ever been 1+, I would, because we know that there's at least some tissue out there.
Yeah.
So if they had changed it, so let's say they had never received trastuzumab deruxtecan, never received HER2, and they'd had several biopsies, and some of the biopsies were 0, and some were 1, and some were 2, then I would certainly use it in that setting, even if the most recent one was 0.
We have some written comments in. I don't want to ignore the people online. Can I read one of these? Or? Okay.
Sure.
Hi, I'm Deb Mueller from right here in San Antonio. I happen to work at UT Health. I'm a surgeon, so I can read literature pretty well, and now I'm a breast cancer patient as well. Can you tell me, with these early treatments, I was a little discouraged in my own case that there was no even capture of who had ductal versus lobular cancer for abemaciclib. So I can read that study, and I still don't know is that right for me. I technically would qualify. In the TALENT study, are they at least capturing, the baseline? Because there are differences expressed in a lot of the literature about how they would respond.
In terms of lobular versus ductal. So we're capturing that data. That data is certainly able to be captured. As far as I know, in TALENT, there is no pre-planned analysis for ductal versus lobular. It is certainly an exploratory endpoint that I think makes sense. And, I think that it's, when I was putting patients on the study, or at least thinking about, who should I, say, listen, you qualify for this study. I think it's something you can do if you'd like to, versus like, I think this is a great study for you. It's really the node-positive patients who have lobular breast cancer who don't tend to respond well to chemotherapy, and we're really relying heavily on the hormone-blocking therapy to do all the heavy lifting. Those are situations that if I saw someone who was a 2+ lobular patient, I was like, oh my gosh, this would be so interesting to know if this really works. And so as far as I know, it's not a pre-planned analysis, but it's certainly something that I think could be looked at because we do have that data. And it's an investigator-initiated trial, so Dr. Hurvitz has the ability to really make sure to collect all that data.
Don't miss her presentation. Here, we're going to have to go backwards on these questions, but if FISH is go down. Is there evidence that ILD risk increases with longer-term use of HER2?
So because it can happen really at any point, it doesn't necessarily increase with longer-term use, like that at some point everybody will get it, but it can happen really at any point. And so it does increase it in that sense, but not like a cumulative dose, not like with heart failure and anthracyclines where, as the higher the dose gets, you will just increase the chances of having that event at some point.
I don't understand that second one. So are people with HER2 positive or HER2 low lung mets more likely to experience the...
So it's not something that we've specifically seen. We still will give it to patients who have lung metastases. But I think that if we're all honest with ourselves, we're definitely more nervous to give it to patients with lung metastases, but it can still be done.
Probably don't give it to smokers either.
Well, I'll give it to a smoker, but not many smokers in Los Angeles. So.
This is true. Come on to Texas. Would an MRI be a viable option to a CT scan to reduce the radiation risk?
That's a great question. I mean, especially like thinking about something like an ultra-fast MRI, there's some breast protocols that can do that. I mean, the trouble with MRI is that they're so much more time consuming. It's a longer study to get done throughout the whole lungs too, which is a pretty big area. I think that it would be a great way to look at that, but I don't know how well one would think that you're just as likely to diagnose pneumonitis with an MRI of the lungs, but I don't know how, if most of the data is with CT.
Right.
I think that there's no reason to think that MRI would be any worse. It would probably be just as good, if not better. But it's fewer patients can tolerate MRIs. They are much longer examinations.
Yeah.
So I think there's challenges to it, but there's less radiation, and I think that certainly that would be a very, very interesting thing to look at, especially if you could do a faster protocol. One that there have been some studies in screening MRIs for BRCA patients who need to get lots of MRIs if they don't have a bilateral mastectomy, and then there were these ultra-fast protocols. They still haven't been adopted quite as much yet, but yeah.
And I love this one. If FISH technically a more reliable measure of HER2, why doesn't pathology just agree to do FISHes on everything?
It's because immunohistochemistry is so much easier, and it's so much less costly. You don't need a specialized cytogenetics laboratory to do it. You can just, immunohistochemistry is like, it's like the Swiss Army knife for pathologists. I mean, they use it for everything. And so if you can get the vast majority of your answers with immunohistochemistry, why do a test that is going to be a lot more expensive, take a lot of time to perform, and also require a high degree of expertise to get it right?
Thank you. I just wanted to ask a question about resistance. I haven't heard that kind of topic yet. So I'm on HER2, and so obviously my top of mind is how long will this work, right? As like with the estrogen receptor, it can either, you give, CDK4/6 or an AI, and eventually either you lose the estrogen receptor or it becomes resistant to the estrogen receptor. Is there any data to know how this is going to respond? Like with HER2, people who are truly HER2 positive, they can stay on Herceptin for many, many years, so they don't necessarily, I don't know, maybe they do eventually lose their HER2 positivity as well, or it becomes less sensitive. Is there data to think about what's going to happen if someone is 2+? Do you lose the receptors themselves, or does it just become more resistant to accepting or being sensitive to the drug?
So, I think that we're still in the early stages of trying to understand this in general, because it's, especially in HER2 low breast cancer, it's only been approved so recently. And so we don't really have a lot of data in the real world setting to try and understand what are the biological changes that happen within the tumor after this. Now, because we're killing the cells not really by putting pressure on the HER2 pathway, but we're killing them really with standard chemotherapy, but just in a different way. My suspicion is that we're not going to see this kind of what's called downregulation of HER2, where someone may be 2+ and then later they're come out to be 0 on the other end of it, or as what happens in HER2 positive breast cancer, we can often see loss of the HER2 receptor expression later on after eventual resistance to Herceptin. I think in general it is a area of study where we don't have a lot of great studies that look at that topic in general. We have some. Partially, the pace of breast cancer treatment is moving so fast that it's, once you start a study, you have a totally different patient population in the real world by the time you finish the study, and so your results don't necessarily still hold water or are necessarily relevant in the real world setting. So I think that's one of the biggest challenges to doing this research and why we don't see a lot more of it. But it's something we're gonna have to pay attention to, and we don't have a lot of that data right now.
So kind of speaking on that HER2 variability, if you had early stage disease and then there was like a decade of time in between your metastatic, would you prefer to look at the lymph node or the biopsy from the metastatic disease versus the primary?
If there was a long period of time in between them, I would look at both. If there was, it would depend on a number of factors. So I think if there were multiple sites of metastases, then I would be more interested in what the original one showed. If there was a very long period of time, then there was a single area of metastases, I'd be more focused on what that on what that one showed. But I would always take both into account.
So we have a question back here, and then I have a question for you as well.
Thank you. Hi, Dr. McAndrew. There's been a lot of talk about the ILD side effects. Can you talk a little bit about some of the other side effects? And since it is used with chemotherapy, why is it better, and why is there so much more excitement about an HER2 before going to a standard chemo alone?
Do you mean in the early stage setting?
No, in the metastatic setting.
Okay. So in the metastatic setting, it itself contains chemo, but we don't necessarily use it with chemo. Was that your question about that, or because it's used as a monotherapy? It's not used in combination with other treatments. In terms of other side effects, I'd say nausea is probably the most common other side effect. So certainly we have to pre-treat with Zofran. And oftentimes I'm pre-treating with Amendin and really increasing my anti-nausea regimen like I am with other standard chemotherapy regimens. So that's a big one I counsel patients on. I definitely see more hair thinning in HER2 than I do on Kadcyla. With Kadcyla, you don't really see much hair loss. You can sometimes see some, but I'd say most patients don't have a lot of hair loss on Kadcyla. Most patients do have pretty significant hair thinning on HER2. But the nausea seems to be really the big one that people will oftentimes complain about. And of course, we still do monitor the heart because it is a trastuzumab-based drug. We still monitor the echocardiogram every 3 months.
Are there reports of increased cardiac toxicity from Enhertu?
There haven't really been. I haven't seen anything in the studies that showed that there was any new signal.
Okay. So please, again, raise your hand if you have a question.
Just a very, very small plug for that, somewhat related to that. Please feel free to drop by my poster on Wednesday at 5 o'clock. I did a large study in the Serum Medicare database looking at long-term cardiac outcomes with trastuzumab, plus or minus an anthracycline in curable breast cancer, so patients who received it for early stage breast cancer. I looked at tens of thousands of patients who had received Herceptin compared to a couple 100,000 who had not received Herceptin, and looked to see whether or not there was an increased risk of long-term heart failure, not talking about the short changes in ejection fraction when you're monitoring, but years and years later down the line. So.
But he won't tell you the
I
answer.
won't tell you now.
You have to come to the poster
You'll have to
session.
come.
Here's one from online. Are patients that have had radiation therapy at a higher risk for ILD? Is there anything in the study on that yet?
I haven't seen that was a predictable risk. I mean, it would certainly make sense because radiation can cause pneumonitis, and so the question being, are these patients sort of primed? It doesn't seem that they specifically are, partially because in most patients, they may have already received radiation, and what is there left is now sort of scar. It's not active inflammation. And so it probably doesn't increase the risk all that much. So I wouldn't be necessarily concerned about that. What I would be concerned about is if a patient had some sort of substantial underlying lung injury. If let's say they had radiation a long time ago, maybe they had some high degree of underlying structural lung disease, I would really be worried about tipping them over the edge with additional pneumonitis or lung injury from a drug like Enhertu. So certainly those are situations in which you have to be really, really careful. But I think you can still carefully give it if you're keeping a close eye on things.
So I think it's important to remind everyone in the room that Enhertu at this point in time is not at all approved in the early stage setting and outside of participation in a clinical trial. So it's all still investigatory, and we don't know what's going to happen. But I wonder if you, Dr. McAndrew, could just sort of tell us, what do you think this means for the future of how we classify breast cancer? Is this going to become a new and clinically important subtype, especially as we think about early stage breast cancer?
I definitely think so. I mean, I think that it, as a subtype in general, we have to think, what is the point of even having subtypes? The point is knowing what drugs can work and what you can use to help kill the cancer. And I think it's clear that this is a category that exists now because we have a drug and likely, I think category of drugs that are going to work because how we initially classified these, we didn't have those drugs. And so it's certainly a new category, no doubt about that. But do we need to be really using it in, I think the biggest challenge, especially in the early stage setting, is in which patients do we need to use it? Now, I think that usually the way this kind of thing works is that whenever you have a drug that's of unclear benefit, meaning that we know that chemotherapy works in some patients, we know that the hormone blocking therapy is associated with some degree of benefit in everyone who's estrogen positive for the most part. We know that we have those tools already. Probably the first patients that we want to add in this new drug, should it be approved, would be in the highest of risk patients, certainly, until we can come up with some kind of a study that shows that really adding it in those circumstances is going to be the best thing to do, which is probably how the drug will get approved. I think that you would start by giving it the highest risk patients, which is why the Talent study really only enrolled patients with stage 2 or stage 3 disease. You can argue maybe even stage 2 is too early to apply this drug, or you can argue it's not. I mean, I think it does come down to a really important risk-benefit calculation, and I think everyone's a personal degree of risk that they're willing to accept is different, and so that's why I think that it makes the conversation even more challenging in the office, but it's a conversation that I think is very important to have.
Do we have any other questions? Oh.
First of all, thank you for your visual presentation. I'm a visual learner, so I love the cartoon. It was awesome. I have a comment about fee-for-service versus an employed physician. I've worked with a number of patients who have been recommended to take chemotherapy treatment, and when they shared with me about their tumor biomarkers, I suggested they go to another provider and get the Oncotype test. The Oncotype test showed no benefit from chemo. They returned to the provider, to the setting where it was fee-for-service, and the oncologist said, well, we'll just give you a lower dose. So, as advocates, do you think that it is fair for us to talk to each other about asking your physician, are you a fee-for-service physician, and maybe possibly making a change to a different setting?
Yeah, I think it's always important to ask. I mean, I think that really, it doesn't mean that someone is definitely going to practice in a way that they're always thinking about their bottom line. You can certainly have academic doctors really not thinking about the quality of life and just so laser focused on the guidelines and the data and, not thinking about, okay, who is this human being in front of me and what's their life going to be like if I recommend this? So that's a example in which I think that you can, yes, someone's not fee-for-service or in academic medicine, but maybe they're, not practicing in the best way that would, be associated with a good quality of life. But, and by the same token, that doesn't mean that I think all fee-for-service oncologists will let their bottom line always impact what they're going to recommend. But it's an incentive that's undeniable. And I think it's totally fair to ask, hey, how are you paid from chemo? And I think, unfortunately, not everyone is necessarily savvy enough to ask those questions. They say, you're the doctor, I do what you say. And I think that as doctors, that's something that we have to remember. That's it's not like a power, but it's a privilege that we have, that people trust us so much, and you can't abuse that privilege. You really have to treat that with the respect that it deserves. And so I think that any thoughtful doctor, whether or not they're a fee-for-service or in academic medicine, would hopefully be doing what's best for the patient.
There was a study, I can't remember how many years ago, that basically said most practitioners are sort of like lagging by 10 years standard of care in cancer. So that's one of the issues. If you're an advocate and you're working outside of a major cancer center practice area, one of the things is to encourage the practitioners to spend more time learning the current standard of care. That's a big issue. I think we saw one. We got our 5-minute warning, so now
the lower dose thing that's crazy. Yeah. I've never heard of that.
Well, just as a point of reference, it was right after COVID when the hospital has lost so much revenue.
Yeah.
And I know for a fact from some physicians that they were being encouraged to do such things.
Yeah, I mean, well, there's no other explanation for it because it's just not a thing. It's not like I've just never heard of that being a thing, so that's so strange. I mean, in terms of the lower dose, not in terms of people practicing different because of their COVID in their hospitals.
So I'm going to circle back to what both of you are talking about. It's a huge passion of mine, which some of the advocates know in here, and it's a topic called shared decision making. That is such a key element in the physician-patient communication. And there's so many layers to peel back of that, because patients have personalities, physicians have personalities, and how do you marry those two? But how do you teach that soft science, I call it, of shared decision making? Because we have to encourage patients to be able to ask those hard questions. How many patients do you really know would go in and say, well, are you fee-for-service? They don't even know to ask that. Some of them don't know what it means. And so it's incumbent upon us. That was a great question you asked, and you answered it well, too. It is incumbent upon us to empower patients to be able to ask these questions, but to give them the information. And then we have to respect the fact, do they really want to ask that question? Exactly. I mean, that might not be in their armamentarium, but it might not be in their interest level either to approach a physician about that.
Yeah.
So it's a very delicate topic, but one I encourage all of us in this room to explore more is what I call the soft science of shared decision making. It's something that we have to teach each other and learn from each other on. I'll get off my bandwagon.
Yeah, no, I mean,
huge...
you are preaching to the choir. I mean, I like shared decision making. It's on my bio on my website. It is something that is actually hugely important to me, and probably the reason why I went into breast cancer in general. Because if you look at my waiting room, I'm running real late because I'm always talking way more than I should be if I'm keeping the clock as the most important thing. But, for instance, someone asked me, what should I do about tumor markers? I was told, my friend gets the CEA and the CA15-3 tests every month, and they said that I should do that. Is that something I should do? My life would be a lot easier if I just had a very simple answer to that question. But I think part of the reason why my voice started getting hoarse is because I had 2 patients ask me that question back to back on Friday, and I seemed to be hoarse after that happened. I never quite recovered from it. But it's that's just an example of a situation in which, like, there is not a clear answer, and the answer to it the answer to it lies in what kind of a person are you philosophically? Are you the kind of person who says, I find comfort in having all of the data in front of me, and that sense of control makes me feel a lot better, even if there's nothing I can do about it? Or are you the kind of person who says, like, listen, let me just go back to my life. If something bad's gonna happen, it's gonna happen. I'll keep in touch with you so we can try and see if there's anything going on. But I'm gonna move on from this. And then there's people who are kind of in between. It's a spectrum. And I think a huge part of my job is being able to tease that out of people and sort of help them understand where they are on that decision-making spectrum. And that's one decision out of chemo versus tamoxifen for DCIS versus like all these other sort of things in which there is a spectrum of decisions to make. And there's not necessarily one right decision, but it just takes a really long time to do that. But what I love is that breast cancer patients in general tend to be very, very invested in their care, and they come with great questions. And I love having these conversations, but they take a lot of time. And so, you know, I'm so grateful to my patients for being patient when I'm running behind. And where if it's like a quick visit with nothing to do, I'm kind of like, great, high five, you're doing great. Let me make up some of my time and keep going, but yeah.
Time's up.
Yeah. So I just want to thank all of you for being here, and for those who are watching online, I want to especially thank Alamo for allowing us to bring this program to all of you. And then finally, Beth, wonderful moderation and advocate perspective. And thank you, Dr. McAndrew, for being with us yet again and sharing your expertise and just being an outstanding doctor. All right. Thank you all.